a continuation of transposition of great arteries. If you missed the first one, please take a look on YouTube. It was very nice. And in the end of May, we are going to have 2 sessions from Dr. Anderson talking about the subject of today, double outlet ventricles. So don't miss those. And today, Dr. Silverman is going to talk to us about the double outlet ventricle, and I'm sure this is going to be amazing. On Thursday, the 20th, Dr. Gilbernovsky is going to talk about tetralogy of Fallot. And this is going to be a joint webinar with PCICS, full of very, very good speakers. So you can't miss it, especially if you're interested in intensive care. We are happy to be a partner of the Fetal Heart Society on this very nice webinar. This is going to be on Thursday, May the 13th. We are going to talk about advanced modalities for assessing fetal arrhythmias. I'm sure this is going to be very, very good. Please invite all of your colleagues to join us. And Dr. Mary Cohen is going to talk about imaging of ASD. Her ECHO series has been a big success in Congenital Heart Academy. Everybody loves this. So please join us on the 21st. And Congenital Heart Academy is going to is supporting, is going to have one section on the Baku Heart Days. This is a meeting that has been there for 7 years in Azerbaijan. So we are going to talk about hypoplastic left heart syndrome. Please join us. This is going to be very nice. Our fetal series is going to be on the 27th. We have general topics that Dr. Rima is putting together. I'm sure this is going to be amazing. And something not for May, but for June, that we are going to have the 7th Toronto Cardiac Symposium, which is going to talk about tetralogy of Fallot. And something that is very interesting is going to be the second time that we are going to participate. As we have the host that is handle surgical training. So on this session, it's a one-day entire for that. So the organization sends 2 hearts, 3D printed hearts, and then this is for surgeons. So they're going to do the surgery together and have the tips and the hints and the tricks for doing tetralogy of Fallot surgery. And we are very, very happy and proud that Sasha is going to be one of the proctors on these days. So please type all of your questions on the Q&A chat box for this session of today, and enjoy Dr. Silverman now.
Well, good morning. I'm just a little lost here, Grace. Where do I go from here?
You need to share your screen again, Norman.
Okay. Let me see where I can do that. Share screen. Okay.
And once more, we really like to thank you because we know that it's very early for you. Thank you very much for doing this for us.
It's a pleasure. It's not as early as Friday morning. Anyway, let me just see if I can get this into mode. I hope you can see my screen. Is that okay?
It's perfect. Yes, perfect.
Good morning, ladies and gentlemen. Thank you very much for attending the session. Today, we are going to have a very long session, so I'm going to be quite brief in some of my presentation. First of all, let's begin by looking at the heart development sped up in 3 dimensions. Here's the loop, here's the inner heart curvature, there's the atriums, here's the D loop, here's the corona truncus, and here you can see the heart moving. I'll do that one more time for you. Speed up. This would be the ideal way for us to look at development, and obviously there are problems with this cartoon because the heart doesn't increase in size as much as it would when it was developing. So what I'm looking at is that so-called D loop of the atriums entering through a primitive atrioventricular canal, and then the loop going up to the corona truncus and out of the extrapericardial space. And this is a picture from Dr. Woutlammers and Jill Hickspoor's great presentation, and a cartoon from Professor Anderson, which shows the 3 divisions of the corona truncus over here, the proximal, the middle, and the extrapericardial section of the arteries. And it begins here at Carnegie stage 11 with the two dorsal aortae arising here off the truncus, the primitive ventricle and the veno-atrial connections here. And then we get to the heart at this stage at 13 or Carnegie stage, which is about 5 weeks. Carnegie stage is approximately 2.5 days. So if you can do your arithmetic, 2 13s are 36 and 7 is 33. That's about 5 weeks. So here's the atrial mass. Here is the AV canal. Here's the primitive left ventricle. Here is the so-called inner heart curvature. And here is the primitive right ventricle and the conotruncal area. Oh, I'm going the wrong way. And then here is a picture from Dr. Tim Mohan that Professor Anderson has used to show the heart cut in a position as we saw before. And here is the atrioventricular canal defect lying and draining into this primitive left ventricle. Here is the primitive atrial, primitive interventricular foramen. And here is the outflow with the conotrungus up here already starting to develop. And what I like about this cartoon is it shows that the flow in the heart comes from the AV canal into the primitive left ventricle, and then through the primary atrial, the primary ventricular communication, interventricular communication into the outflow tract. And here you can see that the heart begins, in fact, its story as a double inlet into the left ventricle and starts also as a double outlet right ventricle. And this is the topic of today's conversation and how this develops. When the AV canal separates and shifts over, then that primary interventricular communication is placed or is replaced by a secondary interventricular communication. And then lastly, when the valves are developed and the aorta has shifted into the left ventricle, there is left a tertiary interventricular communication, which is what we call a ventricular septal defect, and that is closed by tubercles of the cushions and also tubercles on the conotrungus. So here you can see in a later stage of development how this occurs. And now the spiraling of the truncus with the aorta having to come down and lie within the left ventricular outflow tract. At the same time, the conotrungus is developing, with this being the primitive 6th arch and this the primitive 4th arch. And these are spiraling down into the ventricle. You can see that here the aorta and pulmonary artery have separated, and that the primitive proximal ends are still unfused. And here you can see the intrapericardial trunks, the distal outflow tract, and the proximal cushions early on. And then the spiraling as they separate that occurs here that brings the aorta into the left ventricle and the pulmonary trunk into the right ventricle. And you see the proximal cushions are the last to fuse. And here is a picture of a histological section showing the spiraling of these two proximal cushions. In a heart that has had a knockout genetic communication, here you see the cushions are unseparated and that the cushions have not spiraled. Let's just look at that again from there to there, that this is an unspiraled cushion, and that this would then lead to a position of double outlet right ventricle. Now, when we look at standard textbooks, we see the following. We see here the 4 types of double outlet, which is today's conversation. And that is the sub-aortic ventricular septal defect. The ventricular septal defect is in this mauve And you see the two arms of the septomarginal trabeculation with the cushion fused to the ventricular septal defect associated with the outlet septum. So it's to the left. And here it looks like the VSD has moved. Actually, it's not moved. It's the outlet septum which is now fused to the posterior aspect of the ventricular septal defect. And that brings the pulmonary artery into continuity with the right ventricle in a different way. In patients where this has failed to develop completely, the ventricular septal defect lies underneath both of the vessels, and this is then the doubly committed type of double outlet right ventricle. And in this condition, usually the infundibular septum is absent, not always, but most commonly absent, so that there's fibrous continuity between the leaflets of the aortic and pulmonary trunks. And lastly, the remote type of ventricular septal defect, where the ventricular septal defect is distal from the the ventricular arterial roots. And this is called the remote type of ventricular septal defect. And I just want to enforce that where the outlet septum is connected or related to the ventricular septal defect. Here, the outlet septum is related to the left side of the right side of the defect. Here to the left side, and here to neither, and here it is quite distal. So sub-aortic VSD, sub-pulmonary VSD, doubly committed double outlet, and also a non-committed type of double outlet right ventricle. And this has been enforced by a wonderful paper from University of Toronto, which shows in waxed models, three-dimensional magnetic resonance models, this exact feature. Here, the outlet septum fused to the left margin of the interventricular communication, and here to the right margin. So although the ventricular septal defect, or the interventricular communication, as it is appropriately called, is lying within the arms of the septomarginal trabeculation, the fusion makes this different. And here, of course, this is a subpulmonary interventricular communication, and here a subaortic. And this was enforced by a series of beautiful pictures of all of these things that I've just described to you. And here is the reference that you might want with the DOI number of this in circulation imaging published in 2018. And I can certainly commend this paper to you for your understanding. But today we're going to look at what is the ventricular septal defect and what are the margins of this interventricular communication. I'm going to not use the term ventricular septal defect. I'm going to use interventricular communication for almost all of these things. And double outlet is defined by Dr. Richard van Praag, is the presence of both great arteries entirely or predominantly within the morphological right ventricle. So we see here three different issues. We see the presence of the interventricular communication. Here is the last part. And what the surgeon closes is he brings the patch over here to bring the great vessel, which usually the aorta, over the into the left ventricle. So this is the interventricular margin, the left and the right margins of the ventricular septal defect. So double outlet is obviously, I've mentioned this, and on account of the shortness of time, I'm going to let you read this for yourself. But what is important here is that this is a type of ventricular arterial connection, okay? And double outlet cannot coexist with transposition or normally related great vessels, etc. And double outlet can coexist with tetralogy of Fallot, and I'll point out some of the similarities between the sub-aortic ventricular septal communication and tetralogy of Fallot. Double outlet is defined on the basis of the ventricular arterial connections, and tetralogy is defined on the basis of the phenotypic morphology. And double outlet, the channel between the ventricles is roofed by that inner heart curvature, which I showed you on the cartoons, and is appropriately termed an interventricular communication and not a ventricular septal defect. The boundaries of the surgical tunnel lie between the crest of the muscular septum and the great vessels. Now, the issue that we have is that bilateral conuses are not an integral part of the diagnosis. And here we can see two examples from Dr. Tony Lavacek from South Carolina, which shows a tetralogy on the left side. And here you can see this cone of tissue, which is the interventricular communication. Here is the left side, and here is the part that the surgeon closes. Here on the right is double outlet right ventricle, and here you see the so-called inner heart curvature. Here is the interventricular communication, and this is the area that the surgeon closes. Now, the best way to look at this is actually to look at it in short axis imaging. And let me remind you that when we as echocardiographers look at the pictures from this cartoon, we're looking from below upwards. And you can see here in the normal heart that most of the left ventricle, after that conal shift that occurs, finally brings the aorta to be connected to the left ventricle. And here you can see the connection of the aorta to the left ventricle. In ventricular septal defects in the perimembranous type, there is a connection and an override, and in tetralogy and in double outlet right ventricle, the override of this arterial structure, which is failed to reach the left ventricle, lies over the right side. And here is a coronal section showing this, and here we see the normal type of perimembranous VSD, and here is the interventricular communication of a double outlet right ventricle. So you see how the ventricular septal defect and the great vessels lie over the right ventricle. And I'm going to magnify all of these for you so that you can see them, or if you happen to be looking at an iPhone. Now, this is a very complicated slide. I'll only say that in order to look at double outlet in all of its ramifications, a complete echocardiogram has to be done. And here is the essence of today's presentation, which is the showing of the pictures of where the scan plane is of the echo with respect to the specimen. There is a specimen here. There is an additional computerized tomogram over here. Here is a cartoon of the position of the transducer and its axis as it would lie to create this. And then here are the specimens. And in sequence, the scan plane will go away to reveal the underlying right ventricle, ventricular septum, left ventricle, and aortic override, with the interventricular communication being at the back of the specimen. Here on the CT scan, you can see the same features, and you see the interventricular communication with the aorta arising more clearly than the specimen over the right ventricle, with this piece of tissue here being the inner heart curvature, and this the rest of the muscular septum. And here is the outlet from the ventricle. And on the right is the echocardiogram. And as you see on this echocardiogram, both great vessels are arising from the right ventricle, and the interventricular communication is here, and the mitral valve is separated from the aortic valve in this example by this piece of tissue, which is the inner heart curvature. Here is another example in parasternal long axis showing the same features. IVC stands not for inferior vena cava, but for interventricular communication. Excuse me. Okay. And here you can see again the same features. Here is the aortic root. Here is the long area between the mitral valve. This is the so-called inner heart curvature. And here is the interventricular communication. And on the echocardiogram, we can see this both in black and white and in color, that the flow is going through the interventricular communication largely to get to the aortic root. And these will be zoomed in all the time for those of you that are looking at this on your iPhones. Now, here is the more conventional way that we look at this, and that's in a coronal sort of plane. And here you can see the ventricular communication and the right ventricle overriding the ventricular septum. I've shown you this picture before. And here is the echocardiogram to compare with that over here. And here is the mitral valve. Here is the aortic valve. Here's the inner heart curvature. And clearly, this is the area of the interventricular communication in double outlet right ventricle. Now, when we look in short axis, again, we usually have the problem of looking at this upside down, but this example, the apex of the heart has been amputated, and we're looking up as we would look at echocardiographers at the picture of double outlet. And here is the parasternal short axis plane, which I will remove. Here is the scan direction, which we see over here. And here we see this outlet septum with the pulmonary trunk and the aortic trunk identified here. And here is this interventricular communication, which connects the heart to the left ventricle. And note that this tricuspid valve has attachments to the infundibular septum over here, with this being the anterior superior leaflet, this the septal leaflet, and this the mural leaflet of the tricuspid valve. And here, through this heart, you can see the mitral valve through the interventricular communication and the left ventricular outflow tract. And here is the echocardiogram showing the side-by-side relationship of these great vessels. So that's aorta and pulmonary trunk. And you can see that the coronary artery is winding around the back of this. This is a young baby with a thymus present. And now we can compare this to a picture from Dr. Lavacek from on CT scan. And we're looking again up at this over here, but from above downwards now. And here you see the right coronary artery arising from sinus 1 and the left coronary artery from sinus number 2. And here is the position of the aorta slightly anterior and to the right of the aorta, because we're looking from above down, from below upwards. And here on the echo, we're looking from above downwards. So here's the aorta, here's the pulmonary trunk, here's the pantaloon or trouser legs of the pulmonary artery, giving left and right pulmonary arteries. And subcostal imaging is very important. And here is an example of a heart sliced, as it were, excuse me, in a subcostal coronal plane. There's the left coronary coming from the aorta. Here's the pulmonary artery, or the pulmonary trunk, as we should call it, the interventricular communication, and the outlet septum. And we see the left ventricle through the interventricular communication. So both great arteries are arising unquestionably from the right ventricle. The interventricular communication is committed to the pulmonary trunk. And here is an echocardiogram of the same. And these pictures are actually three-dimensional pictures compressed into 2 dimensions, okay? Or sliced to a certain extent. The echocardiogram cannot do that. It only looks at a particular thin 1 or 2 millimeter slice. And here you can see the outlet of these great vessels with the infundibular septum all arising from the right ventricle. The interventricular communication is deep to the synod, and here anteriorly is the small sliver of the left ventricle. So this again is double outlet right ventricle, and I'll just zoom those 3 things up for you so that you can see them in full screen. Yeah, here's a last example of that, with one of the problems that occurs where this outlet septum becomes deviated anteriorly. The aortic root is receiving less blood, and there can be obstruction at this point. And also this patient has a interruption of the aortic arch, which we will see here on the echocardiogram as well. And here's the inner heart curvature. Here again is the interventricular communication, much more closely committed to the pulmonary trunk than the aorta. And also because in this condition, the vessels do not spiral, they exit the heart in a parallel fashion. So here is the interventricular communication. Here is the double outlet from the morphologically right ventricle. Here again is the deviated outlet septum. And here is this aortic arch, which goes nowhere, and the subclavian artery is arising off the distal left-sided descending aorta. So that leaves us to the classification that we have obscured until this point of time, and that was by Dr. Maurice Lev, which he called sub-aortic, sub-pulmonary, doubly committed and non-committed types of double outlet right ventricle. And then there are the types that occurred when there's double outlet without an interventricular communication. And it's rare. We have not seen any echocardiographic pictures of this unless it's been associated with isomerism. But here you see the outlet septum deviated. Here's the right ventricle. Here's the pulmonary trunk and the aorta, right atrium here. And we cannot identify an interventricular communication in this heart. But I thought I would show you this morphological example because this is a work that has been published by myself, Bob Anderson, Diane Spicer, and is available on md1world.com. I'll leave you with the reference, or Grace will give that to you later on. But anyway, there you are, an example of this work that we've put together and which I've used to extract the study for today's presentation. Now, what we need to know about this is nearly half of the defects, if you look at them as a group, are categorized as this form of double outlet. Okay? And the VSD is usually cradled in the arms of the septomarginal trabeculation. By definition, the aorta is closer to the interventricular septum, and the outlet septum is deviated as in tetralogy. Believe that these two conditions can therefore coexist in certain circumstances, and one is described as a ventricular arterial connection, and the other a morphological phenotype. In this condition, the aorta and pulmonary artery spiral as in normal development, and the subpulmonary arterial tract is usually narrowed. And there's often, most frequently, a complete muscular infundibulum because the VSD, or the interventricular communication, is cradled in the arms of the septomarginal trabeculation. So I've shown you this picture before, and in the interest of time, I will just show you again that this is indisputably double outlet right ventricle, pulmonary trunk anteriorly, the aorta distally, and the interventricular communication committed to the subarterial defect. Here is an example of a sub-aortic defect in the morphology, the subcostal coronal plane echo. And you see here the interventricular communication. Here is the inner heart curvature. And the ventricular septal defect is distal to this. Of course, the pulmonary artery is, because of the deviation of the outlet septum, is in a position away from the ventricular septal defect, and the aorta is much closer related to this. And here is an echocardiogram, a CT scan, again courtesy of Tony Lovlacek, who shows that. And this comparison is then perpetuated in the echocardiogram, which is the bailiwick where I live in terms of my association with double outlet right ventricle. And here we see very beautifully the deviated outlet septum with the interventricular communication committed largely to the ventricle, and a scan from back to forward would be necessary to see this here, but is just wanted to highlight this outlet septal area. Now here is a short axis, and this short axis will start up here at great vessel level and then scan down onto the interventricular communication and show the relationship of the interventricular communication to this. Notice that there is no subpulmonary deviation and a large pulmonary blood flow here. This is obviously not tetralogy of Fallot. And here is an example showing aorta and pulmonary trunk. And watch the scan as it goes down. You start to see the origin and the association of the aorta to the mitral valve leaflets. I'm just going to magnify that for you. And I'll stop this here, and I'll show you the relationship of the aorta here. There's the aortic valve to the mitral valve with this interventricular muscle here. And so the pulmonary artery is guarded and separated by the outlet septum here. So this is double outlet with a sub-aortic ventricular septal defect. And here is the example that we get a problem with because it looks a lot like tetralogy of Fallot. The outlet septum is deviated anteriorly and superiorly. Here is the aorta with the coronary artery seen, and the interventricular communication is cradled in the arms of the septomarginal trabeculation, and the conducting tissue would be safe from the surgeon's knife in this condition. And here is the echocardiogram. And you can see the anterior and superior deviation of the outlet septum as we see in tetralogy. And the only way we can put this together as being double outlet is by looking at this in multiple planar analysis and showing that in fact that the defect was bounded by the inner heart curvature and not a problem. Now, as we said, Professor Anderson has emphasized that you can have double outlet with tetralogy. And in fact, in one of tetralogy of Fallot's first 4 cases that he described, one of the patients clearly had double outlet right ventricle as well. So the two conditions can coexist. Now, the subpulmonary defect accounts for 1/4 of the cases. In this condition, the great vessels do not spiral. The outlet septum, instead of being deviated towards the pulmonary route, is often deviated towards the aortic route. That brings the communication above the pulmonary route, and we've talked about its relationship to the ventricular septal defect. There are many similarities between this condition and transposition with the ventricular septal defect, but the interventricular communication is bounded by the inner heart curvature, and defects of the outflow tracts, valves, great vessels, and atrioventricular valves can occur. And in addition, there is maybe stenosis of either or both of the great vessel routes. So here is a beautiful cut specimen of a double outlet with a subpulmonary interventricular communication. And here is a matched CT scan showing the same features of the outlet septum, the interventricular communication, and the relationship to the great vessels. So we look at the outlet septum here, and here we see it on the echo. And you see the pulmonary trunk, the interventricular communication, and the outlet septum deviated anteriorly and to the right, so that the pulmonary route is now brought in contact with the interventricular communication, and the aorta is actually guarded against by the outlet septum. So a subpulmonary interventricular communication. But both these great vessels, I think, override to a very, very large extent. And also there's no relationship of the mitral valve to this anatomy as well. So that's for those who are looking at this on the iPhone. Here's another example, magnified to show the scan plane in the subcostal coronal cut. Here's this large interventricular communication. There's the separation between the mitral and the aortic valve. So in this patient, there are still a separation of the conal tissue from the atrioventricular valves. And here is the Y of the septal band in which the interventricular communication is cradled. And here on echocardiogram, you can see the features of this interventricular communication. Here, the outlet septum is slightly deviated posteriorly, but the pulmonary trunk is arising off the right ventricle, but clearly there is a change as one comes anteriorly into this pulmonary trunk. So here you see the interventricular communication, and with color, we've scanned a little bit cranially and superimposed the pictures. And you see that there is, from the right ventricle, a little narrowing that occurs as we get to the outflow tract. Now, we've seen this picture before, but I wanted to match these three pictures once again. And here you see the outlet septum deviated, the infundibular trunk, the interventricular communication, and the relationship of the great vessels with a slight obliquity to the echocardiogram. Remember, with the echocardiogram, you can turn the probe around on its surface and get a 360-degree rotational aspect there as you do. And this is an example that was obtained by the transgastric view from the transesophageal plane to show this beautiful comparison between the echocardiographic and computerized tomographic images. And here you see the override of the pulmonary route, the anterior deviation of the outlet tract, again with a narrow aorta suggesting an aortic arch problem, indeed double out a interrupted aortic arch in this double outlet with this, the left subclavian arising off the distal descending aorta. But please let me point out to you the separation between the mitral valve and the aortic root in this condition. And here's another example with a different specimen showing this interventricular communication, the inner heart curvature, the pulmonary trunk aorta, outlet septum, tricuspid valve, etc. And now you can see on the CT scan the relationship of the pulmonary trunk here and the fusion of the outlet septum to the left, to the, I beg your pardon, to the right side of the septum here. And here again, the interventricular communication, which I will remove, and shows the aorta and pulmonary trunk arising off the right ventricle with the interventricular communication being small and the inner heart curvature identified here as one of the hallmark features of this form of double outlet. And we can look at this again in long axis and see the same features. This patient, in addition, there's some muscular obstruction underneath the pulmonary trunk, and that's caused the pulmonary trunk to be small and the aorta to be large in this condition. This makes this a very difficult condition to perform a switch, because you get left with aortic stenosis after the switch. So here's an example that frequently happens when there is, as you can see here on the echo, the outlet septum and the ventricular infundibular fold become hypertrophied, and that obstructs the aortic outflow tract. And that's another feature of this form of double outlet right ventricle. And here you can see the outlet septum and the ventricular infundibular fold. Here is the interventricular communication, and there's double outlet from the right ventricle. But what I want to point out, and I'll take this away, you see the outlet septum here, and you can see how this deviation and hypertrophy has obstructed this artery, and it becomes more and more malignant as time goes by. You see also the comparison on the size of the pulmonary and aortic trunks related to the fact that there is aortic arch interruption as well. And as Dr. Van Praag said, when you see this, all the woe lies below, and this is the area where there's the problem, because this is a very difficult area to attack surgically. Now we're going to talk about doubly committed, and this is only accounts for 1/10 of all the double outlets that we've seen. The interventricular communication is non-committed, and there is the key feature is the fibrous continuity, which frequently occurs between the outlets of the aorta and the pulmonary artery. And I'll show you that in rare instances, sometimes there is still an outlet septum. So this picture was supplied by Professor Anderson to me, which shows the interventricular communication, the pulmonary artery. We don't see but a sliver of outlet septum, and it's in fibrous continuity with the aortic root. Here, the ventricular septal defect has a posterior extension into the membranous outlet septum, so the conducting tissue would be exposed in this condition. And what I've done is I've put this in association with an echocardiogram, which shows the fibrous continuity between the pulmonary and aortic trunks, I think, a lot more clearly than you would see it. So superior vena cava and right atrium here. Here's the right ventricle. Here is the aorta. Here is the pulmonary trunk. And here are the fibrous continuity between the leaflets of the aortic and pulmonary trunks together. So this clearly is a double outlet from this morphologically right ventricle. There were other problems. The left ventricle is extremely small, and there was mitral stenosis in this patient as well. So this made the double outlet much more easily understandable in this condition. Here is another one, but I do not have a picture to show you this, but I'm showing you the echocardiogram, which is obtained in that classical outflow view. The great vessels are arising above the right ventricle. The interventricular communication is not identified, but we're focusing on the outlet septum. And here is the outlet septum here in the with the leaflets of the aortic valve and the pulmonary trunk in fibrous continuity. The aorta in this example is a little smaller than the pulmonary trunk, which is the usual case. But in rare instances, there is also the association of pulmonary stenosis. So here you see the fibrous continuity in black and white with its association. And I'll just zoom these up for you. Yeah. And what I'll do is I'll show you this picture again in a still frame to show you can see this doming pulmonary valve there, but fibrous continuity between the aortic and pulmonary leaflets. And then, of course, as the leaflets dome, there you see beautifully the leaflets doming. And of course, associated in Doppler color flow with disordered flow within the pulmonary trunk, which continues for longer than the aortic flow. There's the aortic flow here. And the pulmonary trunk flow is much more disordered and continues for a longer period of time. So that's an example of doubly committed defects. And here is another example with the parasternal long axis and a parasternal short axis cut. And here you see the interventricular communication cradled in the arms of the septomarginal trabeculation, with the pulmonary and aortic trunks equally committed to the ventricular septal defect, to the great arteries. And on long axis, here's the defect here. Again, fibrous continuity here. Maybe a little bit more relationship to the interventricular communication, but nonetheless, double outlet. And here on short axis on the same patient with the ECG sped up a little bit, you can see what reminiscent of what we see in the so-called supracrystal or doubly committed ventricular septal defect without double outlet, that the VSD or the interventricular communication is further over towards on the clock at 12 to 2 o'clock, and there's fibrous continuity between the leaflets of the aortic valve and the pulmonary valve. Now, ever so often, there is an outlet septum, and here you see the outlet septum. Here's the interventricular communication, and this is a 50-50 relationship. So here we have that example, and here we see the same thing on the echocardiogram, a large interventricular communication, and this is all right ventricle on the outlet septum, and the defect is committed to both or not committed to both. But I call that a doubly committed with an infundibular septum. Now you can get this with the remote defect, which is the last one that we talk about, which is also a small proportion of our patients. And here is an example from Diane Spicer's archive of an AV septal defect with the aorta and pulmonary artery arising here. It looks like it's a sub-pulmonary defect, but actually the defect is so remote and that you cannot see it over here. Look, the aorta and pulmonary artery the defect is deep in the ventricle, and these are outlets so that they're compressed and you can't see the relationship. Here is the great vessel relationship. Here's the AV septal defect, usually of Rastelli type C, with without any attachment to the outlet septum. And this is in the proximal area here, the ventricular communication. So really quite remote from this defect. from the double outlet with a little AV canal defect. Now, not all of them are like this. Here is an example which clearly shows the pulmonary and aortic roots, the deviated outlet septum with the septal attachment. We've opened the heart in clamshell view, so we've just lifted the front of the heart open. And here at the back of the heart is an interventricular communication, which I've magnified and put a probe through to show here's the interventricular communication, and remote from this, here are the double outlet of the right ventricle. Okay, so look where the interventricular communication is, way back in the ventricular septum. And here, of course, you see the beautiful example of double outlet in its pristine form. Now, defects can exist all over. Here's a small restrictive defect, which is remote. You see where the interventricular communication is, and it's very bizarre shape. Okay, very much distal in the muscular septum from the great vessel roots. And here is the interventricular communication on the echo. I've left the arrow over where the defect is. So this defect is really remote from where you see it in that position. Once again, over here. And here is an example of a defect in the inlet septum associated with double outlet. And remember, we're looking at 3 dimensions compressed into 2. On the echo, we can separate that much better. Here are 2 interventricular communications. The left ventricle is lying inferiorly over here, and the outlets are up here. So here is the classical feature of double outlet, which has not formed embryologically, but the defects are really quite distal, and I will remove that and make it larger for you so that you can see that. So here lies the left ventricle. It's the superior inferior ventricles, double outlet, and 2 interventricular communications within the muscular septum. The left ventricle is small. Here is another example that I obtained on my travels, and here you can see I've shown the infundibular hypertrophy over here with the small aorta and pulmonary trunk, and the superior-inferior relationship of the ventricles. So that's the right ventricle, clearly with double outlet. If you just look here, there's obstruction of the aortic outflow tract here. And here below is the left ventricle above the right ventricle, and here the interventricular communication. So the complexity of double outlet can be actually quite phenomenal. And I think this is such an example. I'll just zoom it up so that you can make that comparison again. So here is the little left ventricle. It was larger in other planes, but clearly separated, and the outlet deviation causing obstruction. So a really complicated heart. Now, coronary anomalies are a problem in this condition. I think they are more common than you see in transposition. In 62% of patients, they're normal, but in the rest, they are abnormal. And what we need to worry about is intramural course, the origin of the circumflex from the right, single coronary artery from sinus 1, single coronary from sinus number 2, and the double loop pattern. And I have a simple little test for this in examining the coronaries, is to see whether the coronary artery is running behind the pulmonary root. Such a variation can be easily seen in the subsequent views that I'm showing you. And when a coronary vessel is identified behind the posterior great roots, it points to either a circumflex coronary arising from the right coronary from sinus 2, a single coronary artery from sinus number 2, or a double loop pattern. So here we are, we show you those patterns. So here is an example of the malalignment of these vessels, which are associated with abnormalities. Here is the normal coronary artery arising from this sinus and this one here, and this is the non-facing sinus. And I have a cartoon to show you the circumflex coronary artery and the left anterior descending. So this is in actual fact comes around here, and it goes into the coronary here. So here, let's look at the cartoon, which is made for this particular picture. And here we see the coronary artery running behind the pulmonary root here and going into the left anterior descending and the circumflex coronary artery. And here below, you'll see from the subcostal coronal, you see the pulmonary trunk and you see the great vessels. What I'm going to do is, first of all, I have to make a correction here. Here, the coronary arteries are running normal, but they are malaligned, and this is the kind of abnormality or malalignment of the commissures that is associated with coronary abnormalities. So here we'll see, as we look here, we can see as we still frame this, here runs the coronary artery behind with the left anterior descending and the circumflex running around here. Now remember that the heart is twisting and moving up and down within the thorax, so you only see these abnormalities for a short period of time, and they may be synthesized by the eye to be real. So here you can see the whole artery running off this sinus here, behind the heart, side by side great vessels, malalignment of the cusps, and the single left coronary artery here. And here subcostally, in this zoom frame, you can see, as I'll stop this, here is the left coronary artery running behind the pulmonary artery, and here is the right coronary artery, and they're joining together to go into this trunk. Let me just show you that. See there? And then they disappear. And then you see the right coronary beautifully. And then as the heart twists, you see the left coronary. And then you see nothing. So when I run that in real time, you can see how these two vessels can be seen. The left coronary artery is running posterior to the right coronary artery, and this is a single coronary artery. The cusp malalignment is often associated with these abnormalities. And here what I've done is I've put the cusp commissures down here. You see them here, and they are clearly not aligned as they would be, and I've shown this here. And here comes an intramural coronary artery, which runs a course off the same sinus, crosses the sinus, and runs between the coronary arteries. And here is this left coronary artery coming from here and running between the vessels. So here we'll see that in a minute. Okay, there's the malalignment. And here you can see the coronary artery with its inter-arterial course. So this is certainly a big surgical problem. Fortunately, today we have CT scanning to allow, and angiography, which allow us to get a look at this. Now, double outlet is the most complicated lesion and is associated with many, many abnormalities. For example, mitral atresia. And here is an example of mitral atresia. There's the left atrium. Here's a sliver of the left ventricle. It's on this side. Here's the interventricular communication. In short axis, you can see the interventricular communication. Here you see the double outlet from the right ventricle in short axis above. And in an apical view, we can see that there is no communication between the left atrium and the morphologically left ventricle. And here is the interventricular communication. So here is an example of how all three planes need to be put together in order to make this definition. And of course, the aorta is posterior here and small, and this is really physiologically a form of hyperplastic left heart. And here you see the absence of the connection entirely between the morphologically left atrium and the morphologically left ventricle, as we saw on the specimen. Okay, here's AV canal, and I've shown in this example, here is the ostium primum, ostium secundum defect as we look back on this ventricle. And here is the deviated outlet septum with the narrowing of the pulmonary trunk as we see it here. And the picture that I've shown you here is a patient with dextrocardia and situs apparently situs inversus. But we will look at that in a different view here. And we see what looks like a narrow appendage here. So this is a morphologically left atrium. And here is another narrow appendage here. So this patient has bilateral left atriums, an AV septal defect, and double outlet right ventricle. And here it looks like it's doubly committed with an associated stenosis of the aortic trunk. So the complexity of these cases is tremendous. Arch abnormalities. Here's a patient who didn't have an interruption, but had a near interruption. You see how narrow the vessel is. The subclavian vessel is arising off the distal descending aorta. And here is the whole transverse aorta, a large arterial duct. This is a suprasternal sagittal cut, as I've shown here on the specimen. And if I take this away and zoom in on it, you'll see that very beautifully. Here's another example with associated AV canal defect. And what we can see here is that this distance between the subclavian arising from the descending aorta and the other vessels of the head and neck arising from the proximal aorta is approximately 2 centimeters, as you can see on the scale over here. And here we can see on this basis over here, when we look back, that this is an AV septal defect with double outlet right ventricle as well. Coarctation is usually not simple. Here's a preductal shelf. Here is the duct going into the descending aorta. And here is a comparative echo in double outlet, big right innominate. You can see how small the aortic arch is. It's smaller than the innominate vessel and almost the same size as the right pulmonary artery. And that there is a long area of narrowing across this region here, with a coarctation occurring here, and this being the sleeve of the ductus here. I'll just make this larger for you so that you can see it. You see where the ductus is draining in here. Here's the origin of the duct, and this is the aortic end of the ductus, and this whole area is a complex area of stenosis. Here's the innominate, the subclavian, and the carotid vessel in the proximal area. Here, associated with double outlet, is the so-called cleft in the mitral valve, which is the superior and inferior bridging leaflets, as we look at them from the left side, an associated muscular VSD. And you see that when you get this, here is the ventricular septal defect viewed from the left. This is clearly a left ventricle. The valve leaflets are attached to the interventricular communication. The mitral valve always lacks a communication. When there's a communication, it points to the fact that you're dealing with the analogon of the superior and inferior bridging leaflets, which is what a so-called cleft is all about. And you can see multiple attachments to the crest of the septum with the ventricular communication seen below. This is the other side of this heart. And here you can see the right ventricle with double outlet, deviated outlet septum anteriorly. So pulmonary is a sub-pulmonary defect with a cleft in the valve attached to the ventricular infundibulum fold, as you see it over here. And here is the echocardiogram showing those caudal attachments of the tendinous cords. And here you can see that the valve is tricuspid, but that the valve leaflet is not pointing towards the area of the interventricular septal defect, but is much closer on the other side and way back towards the outlet septum, a common feature of this kind of isolated cleft in the mitral valve. And here's another example of straddle. And here's a straddle going into the left ventricle. You see both valves look like they're draining into the right ventricle. And here's the straddling right AV valve. Deviated infundibular outlet septum causing narrowing of the outflow. Almost nothing seen here. There's the interventricular communication with double outlet and obstructed pulmonary flow. Restrictive ventricular septal defects we've talked about before. I'm getting to the end of my time. I have one, I think, further slide to show you. So restrictive interventricular communication, apical, short axis, and long axis views. Okay, we're emphasizing the same features again. And my final slide, a patient with left isomerism of the atrial appendages. Here they are, two isomeric atrial appendages. This is a postnatal specimen of the baby never breathed at all, came out with the complete heart block, spongy myocardium, left dominant AV septal defect, and pulmonary and aortic stenosis. And I point out this nature of the spongy myocardium. Here's the double outlet from this right ventricle. The apex was on the right side. Here are the two symmetrical isomeric atrial appendages. And here is the echocardiographic example of double outlet, which shows the spongy myocardium here in this fetal example. And clearly here, the double outlet of the ventricles. And this is my final slide. And I thank you for bearing with me. And I thank you very much for your attention. And I'll be glad to answer questions if there are any. Thank you very much.
Thank you, Norman. Very good talk as usual. Thank you very much. And guys, if you want to have these images and more text about it, so go to md1world.com, and there you can have this. This is a book chapter actually, so you can have all the book chapters there. They are very good. I have all of them, and they are really good to use. Okay, so you need to stop sharing your screen, Norma, if you can.
Stop sharing?
Yes, please. We have some questions.
Stop.
I can do this for you. Don't worry. I think I can. Just a second.
I'm unmuted. Okay, Grace.
Okay. Okay, now we are good.
Okay.
Okay, so we have a couple of questions, guys. If you have more questions, please type on the Q&A chat box. So we have first question from Adri, asking how we can predict by echo restrictive interventricular channel for sub-aortic D.O.R.V repair, which need VSD enlargement.
Well, that's a real problem. It's I mean, you see how small they are. If you see flow disturbance across that, you know that it's just a basically, excuse me.
No problem.
Sorry.
Okay.
So, you know, you can see when the ventricular communication is small, and basically you have to tell the surgeon that. Now, the problem about restrictive VSDs is the one thing that I have ever seen Dr. Hanley be concerned about is the restrictive ventricular septal defect, because we know that as the patient grows, the interventricular communication will not enlarge. And that is essentially a clinical problem, because something that may be adequate or minimally restrictive in a young patient can become more restrictive. And we've seen that occurring. And it may require that one has to go back. If you have to, and this is, I'm not a surgeon, but if I were a surgeon, I would have to perhaps consider enlarging the ventricular septal defect. And I would have to enlarge it in a way that I was concerned that I didn't do anything to the conducting tissue. And so under those circumstances, the surgeons know where the conducting tissue is running. I didn't have time to actually do it, and I'm sure that Professor Anderson in 2 weeks will do that again for us very clearly again, is to know where the conducting tissue is running so that you can enlarge the ventricular communication. Or the other option for restrictive VSDs is when they're small, as in some of the examples that I've shown, that you have to consider that these patients are going down a single ventricle repair route. And in that case, the surgery is to enlarge the atrial septum so it's non-restrictive, and do what is necessary on the great vessels in order to go for a single ventricle repair, like banding the pulmonary artery, or in some cases doing a shunt even, depending upon where the obstruction is going. So I think that's what I can say to that gentleman.
Okay. And Sandra is still on this same topic, is asking, when do you say that the interventricular septal defect is restrictive? Is there any echographic measurement or number of gradient or something?
I'm sure that people will develop numbers for this, but I think that, you know, what we get in echo is we get one picture in respect to time. And as I mentioned, I think that this is, you know, when it's clearly restrictive and obstructive, as some of those that I've shown you, then that the ventricle, it's not possible to enlarge that ventricle septal defect. But even when the ventricular septal defect is only minimally restrictive or not restrictive, it can get smaller. And I know that that's one of the cases that Dr. Hanley, in dealing with this, has deferred operation, a complete operation if possible, to see what's happened in that position.
Okay. And Camilo is asking, how can there be a double outlet right ventricle without ventricular septal defect, if misalignment of the septum will always lead a VSD?
Yes, it can occur. The places that I've seen it double outlet is in the situation with left isomerism. And there the AV septal, the canal, the primary canal, shifts over to the right ventricle, and the interventricular foramen closes completely. There's no reason to bring it out because they're all in the right ventricle. So it's a rare anomaly, but it does exist. And it's usually seen in the setting of isomerism, left isomerism. So it does exist. And I mean, I think that was the reason for me showing that example, because it really does exist. It's rare, but it does exist. What is much more common is a ventricular septal defect, I beg your pardon, a double outlet right ventricle with a small hypoplastic mitral component to an AV canal, and that we've seen. And double outlet right ventricle mitral atresia is that situation.
Okay. Miguel is asking if the phenotype of double right ventricle outflow pathway is the same in single or biventricular ventricles.
I don't know how to answer that question. The phenotype of double outlet pathway. I don't know. I don't know that I can understand the question.
I think what he means is that if D.O.R.V is the same for single ventricle or for biventricular repair, if the way the disease develops?
Well, yeah, it's a different part of the development, in fact. I mean, what determines how the canal is going to be is related to, as Professor Anderson has shown in his lectures, is related to that the dorsal mesenchymal cap and the dorsal projection, the vestibular spine of His, and that determines how the ventricle is going to be septated eventually, whether it's double outlet or not. So it's a different part of development, and I would direct that person to look at the videos that we have on the Congenital Heart Academy, where Professor talks about double inlet ventricle, and you will see all of that stuff in the sections. And I think that enforces how important the review of our lectures are, because there's information in there that you really need to go back and look at. And by just simply telling that person to go and look at that lecture on the single ventricle, and there's several, and review that whole thing, I think it will become clearer to him.
Okay, sure. So there's one question about, do we get just the post-atrial appendages with the D.O.R.V?
In my own experience, I haven't come across that, but I'm sure that they can occur. I mean, it's much more commonly seen in tricuspid atresia, double inlet ventricle, and even transposition. I have a pure, simple transposition. And of course, in the old days, people would pray that there would be this, because it was then possible to do a non-bypass procedure where you could do a Rashkin by anastomosing the two adjacent atrial appendages, one to the other. We don't have to worry about that anymore. But I certainly have in my own collection a patient with simple transposition and double outlet from my own archive at the University of California. So yes, it probably can occur. Whether I've seen it or whether anybody else has seen it, I can't say.
Okay. So the last question is about the coronary pattern on this lesion. If the left coronary artery runs posterior to the pulmonary artery, would it not be similar to the normal heart? And is this detrimental for surgery?
I don't know with that. Yes, it could be the left main coronary. You see, I think that this abnormality most often occurs when the vessels are more in a side-by-side position. And I think coronary artery development is a very different issue, because we know that the coronary artery, distal part of the coronary arteries, develops from the myocardial mantle, from the propericardial organ, okay? And the proximal parts are part of the conotruncal development. So where the coronary arteries run embryologically is very, very interesting. It's just they run where it's simplest for them to run. My point is this: regard it as the right coronary artery giving rise to the circumflex, the first part, okay? And when an artery runs behind the pulmonary artery, then it's not the aorta, it's the pulmonary artery that it runs behind. Then that artery can be only one of three things. It can be either the circumflex from the right, it can be a single coronary artery, as I've shown you, okay? And you can have single coronary arteries arising from the front. It's not for me to show that now, but I mean, that really is, you can have a single artery arising anteriorly and crossing, and I've showed that in our example of transposition, which I think is also on the archive. But the point is that when you see that, there's only three possibilities. It's either a single circumflex, or it's a single left coronary artery, or it's what they call the double loop pattern, where the right coronary artery runs round the back and the left artery runs over the arteries on the front. And I think that, you know, that this is not an emergency. And what I wanted to say, which I didn't get a chance to say, is that although echo is a great technique, you know, a CT scan would simply tell you everything that you ever needed to know about the coronary arteries. And as you saw from Dr. Lavacek's pictures, they're absolutely exquisite. And as surgery is not an emergency in this condition, once you've stabilized the patient with good intensive care, there's always the opportunity for a quick CT of the coronary arteries to define it adequately. So I wouldn't worry too much about it if it was there. It's just great that when you develop your skills as an echocardiographer, you can actually see all of these things. And certainly when I was practicing vigorously, many of these patients would go to surgery without any problems. And I think still that is the case because the surgeons have developed great skill about understanding coronary anatomy and how to fix it. So they can fix almost anything with their surgical techniques these days. And this is just only one of a small number of problems that they have to fix in double outlet.
Indeed.
So I hope that's a good enough answer for you.
I think you clarify things very well. And thank you, Norman. It was really, really good. It was really, really good. Thank you. And I'm sure this is going to be consistent with Dr. Anderson's talk on the next 2 weeks. So this week he talks about TGA, and I hope you join us there as usual. And then the next 2 weeks, he's going to talk about double outlet ventricles. So I'm sure the combination of these 3 talks are going to be amazing. His 2 talks and your talk about this correlation with echo. I'm sure this is going to solve all the doubts of everybody about the double outlet ventricles.
Thank you very much, Grace. And thank you, Sasha. And goodbye, everybody.
Thank you, guys.